This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hey, this is Jason Crowell from Norton Neuroscience Institute in Louisville, Kentucky. Thanks for listening to today's Neurology podcast. Today we have YuHong Fu joining us. YuHong is a neuroscientist at the University of Sydney. We asked YuHong to join us to talk about a paper that she co-authored with Glenda Holliday, published May 12th of 2025 in Nature Reviews Neurology. It's titled Dementia with Lewy Bodies and Parkinson's Disease Dementia, the same or different? And is it important? So first of all, YuHong, thanks so much for joining us today. We really appreciate it.
Thank you, Jason. I'm very glad to be here today.
The title of this paper asks the question whether dementia with Lewy bodies and Parkinson's dementia are the same or different. I have to say, this is a topic that I find comes up in clinic all the time. Patients come to me and they're having some cognitive symptoms and they have some Parkinson's symptoms and they're concerned, is it Lewy body dementia? Is it dementia with Lewy bodies? Is it Parkinson's disease? I think this is extremely relevant to clinic. And we're going to talk more about the points that you and your co-author make in this paper. But just to answer the question before we get into the meat of things, are they the same? Are they different? Does it matter? What would you say before we get into the details?
Clinically, we can separate dementia with Lewy bodies from Parkinson's disease dementia by timing, right? It depends on when cognitive symptoms appear relevant to the motor onset. But biologically, they both share neuronal alpha-synuclein aggregation, which we refer to as the Lewy pathology. But for the timing, the brain regions involved and the co-pathologies, they do take different routes. I would say, yes, that difference matters. If we lump them together or chase a single alpha-synuclein answer, we may risk missing the unique mechanisms. And with that, we could also miss the right doors to the future treatments.
Very good. Let's step back for a second. I'm a Parkinson's neurologist, and so I talk about these things quite a bit. But for someone who don't see many patients with neurodegenerative diseases, this nuance may not be something that is thought about very often. But you already touched on it briefly. Just give some more context about the similarities and differences between these two entities. So you've already touched on the timeline. When I was in training and still today, we talk about if motor symptoms come first, that's Parkinson's. If it's cognitive symptoms soon after the year cutoff, or if the cognitive symptoms precede motor symptoms, then we say dementia with Lewy bodies. What else should we know about these two diagnoses as they're currently described?
So yeah, they share a lot the similar symptoms such as Parkinsonism, cognitive decline, visual hallucination, and REM sleep behavior disorder. And also conventional, the key distinction between the two is 1 year rule, but we all know it's not always the case. In dementia with Lewy bodies, cognitive changes comes first, or at least within a year of motor symptoms. So that's why it comes from the 1 year rule. But you will often see a fluctuating attention, visual spatial problems, vivid visual helplessness, and the classic neuroleptic sensitivity that sometimes makes us be cautious about using the antipsychotics. The prodromal can look like mild cognitive impairment or even psychiatric or delirium-like episodes before any motor signs appear. That's pretty much typical in the dementia with Lewy bodies. Whereas in Parkinson's disease dementia, its progression is slower and steady. Many patients with Parkinson's disease developing mild cognitive impairment early, sometimes even at diagnosis, but with the deficits often in attention and executive function. Severe cognitive decline usually appears later and can progress to dementia over decades.
Very good. So that covers the clinical phenotype for these diagnoses. And then in this paper, I would say the bulk of this paper really addresses the similarities and differences that exist with regards to the neuropathology between Parkinson's disease, dementia, and dementia with Lewy bodies. Can you go over that with us, the similarities they have, if we were to look at the pathology, including, if you would, please touch on differences with respect to amyloid? I thought that was particularly interesting.
Although both conditions share the same co-pathology, so that's, we all know it's neuronal alpha-synuclein aggregation or Lewy pathology, the distribution of this pathology and the co-pathology they keep actually can be different. In dementia with Lewy bodies, Lewy pathology spreads widely into cortical regions. And you will often find more amyloid on top. That matters because the more amyloid, the faster cognition declines. In Parkinson's disease dementia, Lewy pathology often starts in the brainstem. Then it can move to the limbic system and the later stage to the cortex. It's a little bit unlike dementia with Lewy bodies. There is much less amyloid along the way. Vascular co-pathology also important. Cerebral amyloid, angiopathy, and white matter changes are more common and more severe in dementia with Lewy bodies than in Parkinson's disease dementia, especially in the parental or occipital regions. That difference may help us to understand why dementia with Lewy bodies sometimes presents delirium-like episodes.
There's a difference in regards to where the neuronal Lewy bodies are found. You said more brainstem in Parkinson's, more cortically in dementia with Lewy bodies. And then you said with dementia with Lewy bodies, more amyloid, more tau compared to Parkinson's. So now you also spend some time in this article talking about the biomarkers that we have available. Can you talk about the similarities and differences with these two diagnoses in regards to biomarkers?
Yeah, I'll talk about two typical used, clinical used. One is the DET scan. So using DET scan, both conditions show reduced dopamine activity in the striatum, but the pattern is different. Say in Parkinson's disease dementia, the loss is more severe in the back part of the putamen, which is a classic Parkinson's pattern. In dementia with Lewy bodies, the reduction is more even, and it actually involves the entire striatum. In that sense, it's including both coded nucleus and the putamen. The other one is the typical one, clinical use could be the amyloid PET. I would say this is where they actually diverge. Dementia with Lewy bodies is often amyloid positive, and that signal can appear as early as mild cognitive impairment stage. When amyloid shows up, it usually indicates faster cognitive decline. For Parkinson's disease dementia, on the other hand, the majority is negative on amyloid scan. There is a recently newly discovered technique. It's called alpha-synuclein seeding amplification assays. This is something I have to talk about. This test can spot misfolded alpha-synuclein in the spinal fluid or in the other blood samples even before symptoms start. So they are very sensitive and promising, but they are not quantitative yet. So in that sense, they are not precise enough to measure disease severity. And it can also mean changes in specific brain regions that we know already typically impact different in DLB and PDD. For now, these assays work best as part of a larger biomarker panel rather than on their own.
In this article with the following quote, I'm going to read it back to you. We strongly advocate expanding the biological construct beyond alpha-synuclein for divergent phenotypes of Lewy pathologies rather than considering them all on a similar path. So in light of the similarities and differences that you've touched on clinically, pathologically, with biomarkers, can you just make the case for us about why you think it's important to further differentiate these two diagnoses rather than lumping them together?
Because alpha-synuclein alone doesn't explain why these conditions behave differently. Say, dementia with Lewy bodies and Parkinson's disease dementia share the same code, but they actually differ in how fast they progress. So that means prognosis is different. And also, we just mentioned the DLB is actually more sensitive to the antipsychotic medications. The types of the symptoms they cause are also different, and how they respond to the treatment are different. So that actually involved the different clinical management. Other factors like amyloid, tau, vascular changes, glial responses, and even the lipid patterns can shape the disease in unique ways. If we treat them as one uniform Lewy body disorder, we miss all that complexity. A single alpha-synuclein model cannot really predict risk or tell us which brain region or which networks or which neurotransmitters are actually most vulnerable. By studying this difference, we can create clear phenotype-specific roadmaps, designing treatments that target the right biology in the brain regions that actually impacted at that time. This is how we move towards truly personalized care.
Let me ask you a clinically oriented question, because I started by talking about how often this comes up in clinic. And I feel like it is admittedly confusing for patients who perhaps are getting a new diagnosis of Parkinson's disease, and then they go home and read about these things and come back. So they're already trying to figure out our terminology and the disease definitions to begin with. And then this can be a confusing thing. Do you have any suggestions on how we could explain this in clinic, or do you have any tips on trying to help patients understand these nuances in a way that's easily digestible?
I will say both conditions share the same misfolded protein, alpha-synuclein. So you may not mention alpha-synuclein because it may confuse them, but a misfolded protein in the brain is a common thing for such diseases. And it's under the umbrella of the neuropathology called Lewy pathology, or it's dementia with Lewy bodies. But the timing of the symptoms is different for both. In dementia with Lewy bodies, changes in thinking usually come first. People may notice attention that goes up and down, and they may find they have the vivid visual hallucinations and strong sensitivity to the certain medications. In Parkinson's disease dementia, movement problems is more obvious, such as tremor, stiffness, and slowness. Start years before memory and attention issues appear. We also see different pathologies in the brain. It's more like the Alzheimer's type changes are more common in dementia with Lewy bodies. So I would tell patients perhaps it's the same underlying protein that drives both conditions, but it affects different parts of the brain and interacts with different factors. In that sense, that's why as neurologists, you're aiming for to treat the patients, but with the need to also tailor for each condition to manage symptoms more effectively.
Terrific. I think this is helpful for us to continue to think about. Hopefully, we continue to get more data and better biomarkers that can help us better characterize these diseases and obviously, hopefully, lead to better treatments. So thanks for highlighting this for us. We appreciate it.
Thank you, Jason.
So again, the title of this paper is Dementia with Lewy Bodies and Parkinson's Disease Dementia, the same or different, and is it important? It was published in Nature Reviews Neurology, published on May 12th, 2025. I've been speaking with YuHong Fu from the University of Sydney. YuHong, thanks so much.
Thank you, Jason. I'm very glad to be here today.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.